This is the spinal cord, peripheral nervous system, and critical neuro disorders PowerPoint. We will be looking at spinal cord disorders. In this section, we will look specifically at multiple sclerosis, spinal cord injury, with a focus on autonomic dysreflexia. Multiple sclerosis is an autoimmune disorder. It affects nerve cells in the brain and the spinal cord. Specifically, it attacks that myelin sheath. It causes what's called a demyelination of the nerve cells. So it's like a fatty layer that covers the nerve cells and it begins to break down. That fatty layer helps signals move really quickly through the nervous system. So when it starts to break down, we see that those nerve signals are not moving very well. So you get kind of a jerkiness, you get signals that are not responding. Your brain might know what what it wants its hand to do, but it's not really getting the signals as fast because the breakdown in communication. This can be something that is irreversible. Symptoms can come and go. There's no cure. It is something that it will get progressive, and we have to work on maybe slowing that progression down. There are 4 types of MS. The first one we're going to look at is this relapsing remitting. It is the most common form of MS. It affects twice as many women as men. Typically, the onset we see in the 20s and 30s. It is characterized by relapses or exacerbations, during which new clinical manifestations appear and old ones worsen or reappear. These relapses can last days or months. Relapses are followed by periods of remission during which the patient has either a partial or total recovery. This can be slow or almost instantaneous. So we are also going to look at secondary progressive, which is that second type of MS. Patient is initially, they have that relapsing remitting. It develops gradual worsening of the disease. The early phase, the patients still experience some relapses, but these will progress into a general deterioration. Although some improvement may be seen after a relapse, no real recovery occurs. The third type is the progressive relapsing, progressive course. It does have a gradual worsening of clinical manifestations from onset, and the relapses may or may not have recovery. Then there is a primary progressive, gradual progression with no remissions. However, there may be some temporary plateaus. This form affects men and women equally and typically occurs in the late 30s, early 40s. Initial disease activity is in the spinal cord, not the brain, so these patients are less likely to develop cognitive problems. Because clinical manifestations can be intermittent or mimic other diseases, and there is no specific test for MS, it can be difficult to diagnose. Therefore, a patient may not be diagnosed for months to years after onset of clinical manifestations. The diagnosis is ultimately made by ruling out conditions with similar clinical presentations. A detailed history, physical, and neurological examination are performed. For a definitive diagnosis, the patient must have at least 2 separate symptomatic events or an MRI in which we see changes in at least 2 separate locations. These are some of the clinical manifestations of MS: fatigue, dizziness, pain, tingling, diplopia, some double vision, some vision loss, optic neuritis, different changes in vision, dysphagia, tinnitus, nystagmus, bowel and bladder changes, cognitive changes, electric shock sensations with the head movement. These can be very subtle, these can be quite profound. It just depends on how the disease is manifesting itself. When we assess MS, we're going to look at several different items. Neuromuscular function, so we're going to evaluate for changes in the clinical presentation or for new symptoms to be addressed as the disease progresses. And the new areas that have that demyelinization. We're going to look at the vision and eye movement because that demyelinization of the cranial nerves can result in optic neuritis, causing vision changes. We're going to look at skin integrity, Immobility does promote breakdown as a result of compression of soft tissue between bony prominences and any external surface. This compromises blood flow and decreases delivery of oxygen and nutrients to cells, resulting in cellular death and injury to the surrounding tissues. We're going to assess our ADLs. We need to evaluate for any assistive devices to decrease the danger of falls. Weaknesses, bathing, all of that needs to be assessed to see the functionality of the patient. We're going to look at the bowel and bladder function. Any impaired in nervization of the bladder and bowel may result in incontinence and constipation. Some nursing diagnoses to consider: impaired physical mobility, self-care deficit, impaired coping. All of these diagnoses really relate to how the patient is getting along in the world, if they can take care of themselves, if they can get around, if they can function. And if they can't, we're dealing with a decline in function and, possibly some depression, some frustration, aggravation, different situations. This is not an exclusive list of nursing diagnoses, but it's definitely ones to consider. Here are some of our nursing interventions. We're going to encourage range of motion exercises. This increases venous return, prevents stiffness, maintains muscle strength and endurance. We want to encourage mild to moderate activity. We do not want overexertion because that can cause flare-ups. Physical therapy is often beneficial. It helps determine kind of appropriate activities, and we would be able to then avoid overexertion. We're going to look at our medications. Specifically, a lot of what they use was the interferon beta-1b, and that is used to decrease exacerbations and slow disease progression. You may also see them ordering corticosteroids. It does typically result, from some sort of stress, and these administrations of corticosteroids decrease that inflammatory process associated with the flare-up. So we're also going to implement safety measures. We will see during that flare-up that change in mobility, change in sensation, change in vision, and our patient is then at a higher risk for falls and for injury. One of the things they might do is an eye patch. So if they are struggling with visual deficits or diplopia, we're going to patch one eye daily and then the other eye the next day, or even several times a day. It will help improve balance and vision. Also important to maintain an ideal body weight. Impaired mobility increases weight gain, and increased weight is associated with complications with mobility and fatigue. So that's something we definitely want to encourage our patients to work on. And we want to review the disease process and prognosis. If we help our patients understand how we can make these improvements, then they are certainly going to make informed choices. These patients should be well informed. It'll help them guide, decision making, and help them manage their diagnosis. So our MS education involves taking medications as ordered, resting, what do clinical manifestations of the exacerbation look like, vision scanning. We want to look and make sure we're aware of any deficits. Check water temperature. Since you can have that numbness, you may not know that your water is way too hot or way too cold, so definitely check it ahead of time. Maintain ideal body weight. Review that disease process and prognosis. Self-catheterizing procedures, if that's something that they have to do. All of this needs to be reviewed depending on how advanced their MS is and how they are affected by it. We're going to spend some time talking about spinal cord injury. The risk factors you see here, the ones who are most likely are the young males. We have high risk physical activity, driving under the influence. You'll find a lot of young people in general have that kind of bubble where they will engage in risky behaviors and they don't understand the permanence of their actions. They don't have that that self-awareness to realize how fragile they are, and they tend to make some bad decisions. Not obviously every spinal cord injury is because of bad decisions, but we will see that a lot of spinal cord injuries, car accidents will be like 56% of them, falls 14%, gun violence 9%, and sports injuries 7%. So, even with our young athletes, we need to make sure that they are protected, their backs are protected, their heads are protected. Most common, we see injuries at C4, C5, C6, and T12. A lot of these injuries can relate, they can result in paraplegia, and then some even in quadriplegia. So we need to educate very, very seriously our young people because they can have a lifelong disability. So there's different types of spinal cord injuries, complete injuries, incomplete injuries, normal functioning after an injury. We do not expect that you're going to be able to diagnose any spinal cord injury. Just understand that it really varies widely from injury to injury. Nerves are all very different. Where the injury occurred, what kind of healing, what kind of swelling, what kind of interventions were done. That can all affect how these heal and how their long-term manifestations are, how we're going to see them. So please don't memorize this slide by any means, but just know that there's different types of spinal cord injuries. Our clinical manifestations of a spinal cord injury can really depend on the level of injury. It depends on where it happened, what kind of recovery, what kind of inflammation. But these are some examples. You could have an inability to breathe. You could have paraplegia, loss of bowel bladder or sexual function. You could have chronic pain, hypotension, and impaired temperature control. So it just depends on where this has occurred. This is an illustration of our dermatomes. It shows which area of the body would be affected by the level of spinal injury. The level of principal dermatomes gives you an idea of where it would start and that innervation from the vertebrae. So typically T4 is at the level of your nipples. So again, it just depends on where it's at. So where the injury is at, generally what kind of innervation problems we would see. So diagnosis and treatment does vary. So one of the first things we have to look at is time between our injury and between injury and treatment. It can greatly affect the patient outcome. If the patient is admitted with a suspected spinal cord injury associated with trauma with the head or neck, the spine is immobilized. We're going to use that cervical collar or the spinal backboard until an examination is performed to identify the level of injury, because any significant movement of the spine can result in further damage. A thorough physical and neurological examination, including reflexes, is performed. An X-ray may be performed to look for damage to the vertebrae. If the patient has clinical manifestations of a spinal cord injury, like the inability to move or feel, a CT scan or MRI may be performed to show the location and extent of the damage and to reveal problems such as hematomas. The level of injury refers to the vertebrae closest to the site of injury. Currently, there's no way to reverse spinal cord damage. During the acute stage of injury, treatment focuses on maintaining airway patency, adequate breathing and oxygenation, preventing spinal shock, restoring and maintaining blood pressure, preventing further spinal cord damage, spinal immobilization, and avoiding any possible complications. Patients are monitored for vital signs changes that may indicate spinal shock. This is a halo traction device. You may see this specifically if you're on an ortho floor. It may be your job as the nurse to clean the pin sites, and we're going to be using that cotton tipped applicator. We're going to use some gauze soaked in normal saline, and use a clean applicator or gauze for each pin site. If you see some discharge, some crustiness, we're going to wrap it in gauze soaked with normal saline and then let it soak for about 15 minutes. And then after removing that, you can use it to gently remove the crust from the pin site. Additional information should be available through your facility on how they would like it cleaned. Obviously visit their policies and procedures to make sure you're doing that correctly. There are some possible complications the nurse needs to be aware of. Spinal shock occurs immediately after the injury and applies to all the phenomena surrounding the spinal cord transection. This results in a complete but temporary loss or depression of all or most of the spinal reflexes, as well as sensory, motor, and autonomic activity below the injury level. Depending on the level of the lesion, hypotension due to sympathetic tone loss is a possible complication. This can last from 24 hours up to 1 to 6 weeks, and the return of a reflex activity below the level of injury indicates the end of spinal shock. You can also have neurogenic shock. It is a distributive type of shock that occurs in patients with brain, upper thoracic, and cervical injuries. It is caused by the sudden loss of the autonomic nervous system signals to the smooth muscle in the vessel walls. We also will look more in depth at autonomic dysreflexia. That will be, in subsequent slides here. So we also could look at pin site infections, dysphagia, pressure injuries. All of these you need to be aware of when you are taking care of a patient with spinal cord injury. We're going to look at autonomic dysreflexia. This is an abnormal reaction of the autonomic nervous system to some sort of irritating stimuli. This is a medical emergency. It needs to be figured out very quickly. The symptoms you can see here can be, flushed face, headache, distending neck veins, increased sweating, decreased heart rate, massive vasodilation. This typically happens when we have an injury at T6 or above. The body receives strong sensory impulses like pain, a distended bladder, infection, the need to go to the restroom, having a full rectum. This impulse works its way through the intact nerves and discharges at a level that's just way too high. This causes constriction and severe hypertension. The body attempts to decrease the blood pressure by using the parasympathetic response, and so we have the heart rate dropping. This spinal cord, it cannot receive the message, so the blood pressure doesn't come down. Your patient then experiences a headache, anxiety, and nausea. Flushing can occur above the level of the spinal cord injury, and they will have pallor below the level of injury. So this happens in 80% of patients with an injury above the T5, T6 level. The biggest cause is usually things like a kink in a Foley catheter preventing it from draining, tight clothing, fractures, even something as like a wrinkle in a bed sheet can cause this. These symptoms are diaphoresis, flushing, nausea, and anxiety, the sense of impending doom. The patient will present with severe hypertension and, you have to kind of look at, what we're going to see before, above the injury, and then below the injury, you'll see different things. So be aware of your different symptoms. I'm very, very sure you will see a test question on this disorder, and it's specific to those who have had that injury at the spinal cord in T5 or T6 or higher. Assessment of this patient is going to involve the respiratory function. We're going to You have to understand that there is this loss of intercostal muscle function resulting in decreased tidal volume, and it may lead to hypoventilation. C4 and higher injuries may result in a complete loss of diaphragmatic effort, so your diaphragm isn't working. Vital signs, depending on the level of the injury, and because this is the loss of that input, the patient may experience spinal shock, neurogenic shock, respiratory or cardiac arrest, autonomic dysreflexia. Patients are unable to regulate temperature, and hypothermia may occur because of the loss of control of the blood vessels. So we have to look at motor function, the sensory level, locate the specific injury level used and choose to evaluate the treatment used to see if deficits increase or decrease over time. We're going to have to look at pain. There may be increased pain above the level as a result of damage to the spinal cord or root nerves. And we want to look at input and output. Fluid volume status is important in evaluating the effectiveness of therapies, particularly with spinal shock. Also, with decreased renal perfusion, there is decreased urine output. Nursing diagnoses may be alteration in respiratory function, decreased cardiac output, impaired physical mobility, fear, anxiety. Obviously evaluate your patient and see what is the most appropriate nursing diagnosis. Nursing interventions are as followed. Maintain any suction equipment we need at the bedside. There is a decreased cough effectiveness and the patient may require suctioning to clear the airway. We want to facilitate cough effectiveness because the muscles, they're weak and they have that lack of that diaphragmatic innervation. So again, the diaphragm isn't working very well. We may need assistance to remove secretions. We want to maintain spinal immobilization and stabilization to prevent further injury from an unstable spinal column. We want to perform passive range of motion. It prevents contractures and loss of muscle tone, strengthens unaffected muscles, it does minimize the risk of developing a DVT. We want to look at repositioning the patient and maintain a good alignment, prevents pressure injuries, and it decreases the risks of DVT due to immobility. Perform routine pen site care. We definitely want to, yes, we talked about earlier, make sure we're cleaning it with normal saline. Make sure the gauze is soaked with normal saline and set on the pen site if you've got that crustiness on there. And then you can use that clean applicator to clean off your pen site. There's a variety of things that we can do. Follow your physician's orders, but these are typical to what we see for a person with a spinal cord injury. Education is very important. This is a significant change for someone and it is irreversible. Encouraging the patient to open up and share feelings about this trauma is encouraged without pushing them past their limits. We want to provide emotional support. That can be crucial. The patient should start with small, achievable goals for themselves before looking into any long-term goals. Educate our patients to the clinical manifestations of respiratory distress, because patients with high cervical injuries are at risk for ineffective breathing and cough. They need to recognize these manifestations in order to seek timely treatment. Clinical manifestations, we want to look for that autonomic dysreflexia. It's very crucial patients and their families understand the clinical manifestations as well as causes of this potentially life-threatening emergency, so monitor for triggers. We want to educate patients on skin care, skin management, help identify causes of and skin breakdown. In patients who require a wheelchair, they'll need to be taught to refrain from sitting in one position too long because it can lead to decreased perfusion. So now we're going to switch. We're going to look at the peripheral nervous system disorders. Not all of them. We're going to look at a couple in specific: myasthenia gravis and trigeminal neuralgia. So it is important for you to understand the difference between sympathetic and parasympathetic responses. So take a look at the slide and review those from your pathophysiology. Myasthenia gravis is a motor disorder. It is also acquired autoimmune. It can be idiopathic, which means we really don't know why it's happening. This is what happens typically when the acetylcholine is not able to make the muscle function as it normally does. So we may get some drooping, we may get the inability to raise our eyelids, and that will be some of the first signs. This can be very mild or it can be very severe. Clinical manifestations of myasthenia gravis typically start with the head, with the neck and throat. It is definitely something that you manifest starting in the top of the trunk and then works its way down. 2/3 of patients with myasthenia gravis present with ocular symptoms, namely ptosis and diplopia. Many of these patients experience symptoms within 2 years of the disease onset. It may be, the ptosis may be unilateral or bilateral. Diplopia is a result of extraocular muscle weakness, and ocular symptoms may worsen with activities that require sustained use of the eye muscles. Bulbar symptoms are the first to appear in about 16% of the myasthenia gravis patients. These clinical manifestations include difficulty with phonation, chewing and swallowing, trunk weakness, limb weakness. Sometimes these are the clinical manifestations in initially like maybe 16 to 20% of myasthenia gravis patients. And typically patients experience greater weakness of proximal muscles versus the distal muscles. Although myasthenia can affect many muscles, the muscles of neck, deltoids, triceps, wrist, fingers, and ankles are commonly affected. Weakness varies across the day, but generally worsens late in the day, and clinical manifestations worsen with sustained muscle use. So patients may complain of difficulty completing daily activities of daily living like bathing and dressing. So one of the assessments we're going to look at is assessing breath sounds. We're going to observe the patient's respiratory effort, obtain vital capacity per provider's order. This is usually obtained immediately prior to a dose of the pyridostigmine to obtain a trough value, and then an hour post-dose to evaluate peak effect. If the value is below 1 liter, the patient is at risk for respiratory compromise. Notify the provider. Respiratory deterioration may lead to respiratory arrest. Patients often require intubation and mechanical ventilation in an intensive care setting. Vital capacity measurement. It's important to respiratory function. We want to monitor this. We want to let the provider know if it's declining. So in myasthenia gravis, the patient develops weakness in the diaphragm and the intercostal muscles. Weakness of the respiratory muscles result in diminished forced vital capacity. And this assessment is going to give us the earliest indication of respiratory deterioration. We're going to look at cranial nerves 9, 10, 11, and 12, and make sure the patient's not at risk for aspiration due to difficulty swallowing. We're going to look at dysphagia because we have this weakness in that oropharyngeal muscles. Weakness of the Weakness of the oropharyngeal muscles is going to place the patient at risk for dysarthria and dysphagia. So nutritional intake, output, daily weights. Cranial nerve weakness can make it difficult for the patient to chew and swallow. The patient may become fatigued during the meal. We're going to have to definitely evaluate that. Dysarthria, so the patients may have kind of a nasal quality to the speech and may be at risk for aspiration because of the weakness of these muscles. This is related to that impairment of cranial nerves 5, 7, 9, 10, 11, and 12. With myasthenia gravis, we're looking for respiratory depression, muscle weakness. We're looking for the advancement of the disease. It's certainly something that can be annoying to live with, but if we have respiratory compromise, then it's getting very serious. Our nursing diagnoses are risk for ineffective breathing, risk for aspiration, and fatigue. Administer medications at prescribed intervals and prior to activities requiring swallowing. Pyridostigmine must be administered exactly at the prescribed hour to maintain optimal muscle strength. Patients often take this 30 to 60 minutes before meals to minimize difficulty with chewing and swallowing. Now elevate the patient's bed with eating and drinking. Weakness of the oropharyngeal muscle or muscles can increase that risk of aspiration, and so elevating the head of the bed may decrease aspiration. We're going to establish effective communication, consult with maybe speech language pathology to obtain picture communication boards, because sometimes the verbal communication is impaired by dysarthria. We're going to do some meal planning when medications are at peak levels. We're going to time the meals with peak medication levels because it really decreases that risk of aspiration. Small frequent meals will help maintain our calorie intake. Weight loss may occur from poor nutritional intake. We're going to offer soft foods and thickened liquids recommended by the speech therapist. A temporary feeding tube may be necessary if swallowing is impaired or the patient deteriorates and requires intubation and mechanical ventilation. We need to plan for rest periods between activities of daily living. Use energy conservation techniques, such as sitting a while for activity, while these activities of daily living are completed to minimize fatigue and muscle weakness. Education, we want to let the patient know that it is important to take these medications as prescribed. It's important to teach the patient to adhere to the medication schedule at home because swallowing may be impaired if eating, drinking, brushing teeth, and other activities are not performed at peak levels of the medication. Educate patients to keep the medication with him or her at all times. Spare doses should be kept at the place of employment and in the car. When the patient travels, medication should remain with the patient in carry-on luggage. They should not miss a dose because this can lead to muscular weakness. Instruct the patient to purchase a medic alert bracelet and wear it daily. In the event of an emergency, the patient's diagnosis may be rapidly identified by emergency medical service providers. Avoid public places such as theaters or concerts in the winter where there's large gatherings of people. The patient may be exposed to colds and the flu where large gatherings of people touch door handles and use the restroom and restaurants and all of that stuff, and it increases that risk of exacerbation. Obtain vaccines to prevent the flu and pneumonia. Vaccines decrease the risk of infection. Respiratory infections may lead to myasthenic crises that require hospitalization. We want to prevent fatigue with frequent rest periods. Don't take any over-the-counter preparations without first checking your provider. Sometimes there will be contraindicated, have ingredients that are contraindicated with myasthenia gravis. We want to inform the patient and the family about resources such as the Myasthenia Gravis Foundation of America. And this organization provides detailed education and e-resources for the patients and family. Trigeminal neuralgia. This is another disease we're going to look at that affects the nervous system. This is usually unilateral, severe, brief, stabbing, recurrent pain in the one or more of the branches of the trigeminal nerve. We don't really know why this happens, but it is a severe pain disorder that occurs in cranial nerve 5. This is often characterized by sharp, throbbing, shock-like facial pain. This can be very mild pain, or this pain can be absolutely horrific. This disease has been nicknamed the suicide disease because when it's bad, it's really, really bad, and there's very few medications that can help this horrific pain. So people, rather than suffer, do commit suicide. So It's rare, but it is something that the pain can be absolutely excruciating. When we assess the patient with trigeminal neuralgia, we need to look at pain, including onset, character, and exacerbating factors. It's important to identify pain radiating as well as aggravating factors. The pain is believed to be related to an irritation of the nerve fibers in cranial nerve 5. We want to ask the patient what triggers the pain. We want to evaluate oral intake. Pain may impair oral intake, so it's important to assess oral intake and fluid volume status. We want to look at their weight because this pain can interfere with nutritional intake and the patient may have weight loss. We want to look at the history of exacerbations and remissions because the time between attacks appears to shorten as the patient ages. It's important to establish any pattern. When considering the nursing diagnoses for trigeminal neuralgia, we look at pain, we look at fear, and we look at impaired nutrition. Our nursing interventions include administering medications as ordered, medication taken at prescribed intervals to assist with pain relief have proven to be helpful. They are often using anti-epileptic medications. These have found to have an analgesic effect on neuropathic pain. We also want to look at non-pharmacological strategies such as meditation, diversional activities, support groups, and acupuncture. We want to suggest meditation or diversional activities. Support groups are very important because they can, have members that share their experiences, and acupuncture has found to have an efficacy similar to that of carbamazepine. These interventions are implemented to address pain management through alternative measures. It's been proven that they work very, very well, and the primary concern with trigeminal neuralgia is the unmanageable pain. Education for the patient with trigeminal neuralgia includes avoiding exacerbating factors like cold weather and drafts. The pain is severe and can interfere with activities of daily living, so it's important to minimize factors that cause or exacerbate the pain associated with this disorder. The pain from trigeminal neuralgia can affect the patient's quality of life. The nurse educates the patient about the medications that they are prescribed, including the side effects. Although AEDs are good for pain management, the patient should be educated that indication is neuropathic pain, not epilepsy, so that the nurse may also suggest alternative methods of hygiene that may not aggravate the attack. So again, if you're having a lot of facial pain, we may have to consider something else for your tooth pain that doesn't involve rigorous, brushing, because that's going to aggravate the pain and make it worse. I'm going to discuss some critical neurological disorders. This is not an exclusive list, there's only 2 on here, but these are ones that you're going to see frequently. As far as more critical diseases and disorders that you see in neurology, you're going to touch on that more in in 9th semester in your critical care, but we're going to look at right now some increased intracranial pressure and stroke. So there's 2 types, the ischemic and the hemorrhagic, we're going to take a look at. This slide shows a picture of a man that has increased intracranial pressure. One of the first signs is often the change in level of consciousness. We may see issues with the eye, pupillary changes, impaired eye movement. We can see different posturing, changes in speech, headaches, extremely severe headaches, especially with our hemorrhagic strokes. People will often describe a thunderclap headache sensation where it comes on extremely suddenly and it is the worst headache of their life. That can be a sign of a change in intracranial pressure and possibly a hemorrhagic stroke. We'll see seizures. We can see severe changes in vital signs and vomiting. So at the very bottom of the slide, it talks about infants. This is adult med-surg, so we're not going to really go into changes in the pediatric patient. You will see that in semester 8. So the assessment of the neurological patient is going to happen every 1 to 2 hours during the critical phase, decreasing in frequency as the risk of cerebral edema and secondary brain injury decreases. These assessments are necessary to trend a patient's response to injury and detect subtle neurological changes such as a decrease in the level of consciousness or new motor weakness, signaling intracranial pressure increases. A change in level of consciousness, these are earlier manifestations of increased intracranial pressure as compared with changes in vital signs like, Cushing's triad and motor activity. And the change of shift is important for the oncoming nurse to complete a neurological assessment with the nurse leaving so that subtle patient findings are consistently trended and documented. Vital signs and oxygen saturation should be every 1 to 2 hours. Trending of these vital signs is necessary to detect changes that may signal hemodynamic or neurological instability. Temperature every 1 to 2 hours. We want to look at those temperature elevations that may indicate damage to the hypothalamus. Increasing cerebral metabolism may exacerbate existing brain injury by increasing the demand for oxygen and nutrients where there is existing poor blood flow. ICP should be checked every 1 to 2 hours. Cardiac rhythm, we're going to look at those serum markers of myocardial injury. Myocardial ischemia, injury, or dysrhythmias may occur as a result of neurological injuries such as TBI or subarachnoid hemorrhage. We want input and output every 1 to 2 hours. Fluid balance may be affected as treatments such as osmotic diuretics are administered. Hypovolemia may result in hypotension that adversely affects cerebral perfusion. We want to look at the serum sodium and serum osmolality. We want to monitor the administration of mannitol to quantify the degree of systemic dehydration that has occurred as results of diuresis. So the purpose of monitoring the serum sodium is to determine whether a patient is meeting the target to maintain a continuous concentration gradient favoring the pull of water out of the brain tissue. The typical maximum sodium level tolerated is 160. We're going to look at serum electrolytes. That electrolyte imbalance can occur with osmotic diuresis. Monitoring and replacement of those electrolytes are required to prevent complications of electrolyte disturbances such as dysrhythmias and muscle weakness. We're going to look at BUN and creatinine levels. Patients receiving hypertonic saline, that serum osmolality increases and the risk of acute renal failure increases as serum osmolality rises. So we look at the creatinine and BUN, and these are monitored for indications of renal insufficiency. We're going to look at ABGs, and it is going to allow a precise measurement of gases dissolved in the plasma. It's particularly useful in patients with increased ICP because it allows the evaluation of PCaO2, which causes vasoconstriction or vasodilation, depending on if it's going up or down. Cerebral vasoconstriction can reduce ICP, and vasodilation can increase ICP in the brain injury patient. We're also going to look at end-tidal carbon dioxide. Continuously, it will guide hyperventilation therapy during that treatment of ICP. When hyperventilation therapy is employed, the ETCO2 is monitored in order to maintain carbon dioxide in a very specific range. High-end tidal carbon dioxide values may be higher or lower than the PaCO2. Therefore, it is necessary to document the ETCO2 value at the time that if a blood sample for an ABG is performed so that that correlation can be made between those two numbers measured in that arterial blood sample. This slide has some of our nursing diagnoses, ineffective airway clearance, ineffective breathing, ineffective cerebral tissue perfusion, ineffective thermoregulation, interrupted family processes. Our nursing interventions are going to be maintaining the head of bed greater than 30 degrees. With the patient's head at midline, we want to avoid sharp hip flexion. Elevating the head of the bed and ensuring the head is at midline facilitates drainage of the blood flow from the jugular venous system, decreasing ICP. Avoiding sharp hip flexion ensures that the large veins in the abdomen are not compressed, decreasing venous return. Avoid placing the patient in a position that allows pressure directly on the operative side after a craniotomy. Direct pressure on the operative side may lead to injury of the brain tissue, and it's not protected by the bone that has been removed. Additionally, placement on the operative side may increase ICP. We will only want to do endotracheal suctioning as necessary. Pre-oxygenate with 100% oxygen for 1 to 2 minutes prior to suctioning. Suctioning a patient can increase intracranial pressure and can introduce the risk of further elevation of ICP because the act induces coughing, which raises pressure inside the chest and may transiently reduce drainage of blood from veins in the neck, causing a spike in ICP. Suctioning should be performed when the patient demonstrates mucus in the endotracheal tube or every 4 to 6 hours to maintain patency of the tube. Administering 100% oxygen is used to prevent hypoxia, which can occur during the interruption of mechanical intervention or mechanical ventilation. Administer sedative medications as prescribed. Sedation is used in patients with acutely increased ICP to treat pain, anxiety, and restlessness. Treating these will decrease intracranial pressure when titrated to an appropriate level for a particular patient. When it's given as a continuous infusion, sedative medication should be interrupted for a time adequate just for the patient's neurological assessment to be evaluated. These medications are used judiciously in patients at risk for intracranial pressure so that subtle changes in the neurological assessment may still be identified. We want to administer osmotic agents. Those work by decreasing ICP, pulling water from the interstitial spaces into the vascular space, and then diuresing occurs through the distal renal tubules. High concentration sodium chloride solutions pull water from the interstitial spaces into the vascular space without associated fluid shifts. We want to monitor that CSF draining. So we're going to look at those ventricular drainage systems when applicable. Kinks in the ICP monitoring tubing decrease drainage and may result in increased intracranial pressure. They're going to also administer any antipyretics or implement cooling measures. These interventions prevent an increase in cerebral metabolism that accompanies elevated body temperature. Cooling can be achieved using water-cooled blankets or pads, ice packs. These will be placed in the axilla and groin, or a centrally placed catheter allowing for cool water to circulate around the catheter, so-called endovascular cooling. Education for our patient with intracranial pressure. We will have devices that are used during this course, such as central lines, ICP monitoring devices, endotracheal tubes, and gastric tubes. They may be placed in order to manage patients with increased ICP. Medications. We're going to use several medications like, diuretics, different things. It's different, the ones at home versus the ones we have in the hospital may be very different. We're going to educate them about complications. Many complications of increased ICP may occur and are regularly associated with the primary cause of elevated ICP. We want to have, give them the rationale for any helmet use after the increased ICP, especially after a craniotomy, because the brain is not protected, and the importance of allowing a patient to rest. We need to allow that person to be rested because that constant stimulation may exacerbate increased ICP. So we're going to switch the conversation to talking about stroke. Risk factors include smoking, diabetes, family history, clotting disorders, TBI, hypertension, drug use, gender, and age, including also this atherosclerosis. So there's a couple main types of stroke. Are ischemic, which means it's basically kind of a chunk of something that got stuck in a vessel, or a hemorrhagic stroke, meaning it's a bleed. So we cannot give them TPA with the hemorrhagic bleed because the TPA will cause more bleeding, so that actually kind of makes it worse. We also have this thing called a TIA, which is a trans-ischemic attack. It's a little tiny piece of chunk that kind of stops up in the brain and then causes stroke-like symptoms, but then it moves along. It doesn't do a complete blockage. The most important thing to know is the onset of symptoms. When did you see this person last normal? That will help us decide what the window of time is and whether or not we can use TPA. TPA cannot be used with somebody that has an intracranial bleed. Our gold standard for diagnosis is a CT scan. Anyone presenting with stroke symptoms gets a CT immediately. These are our emergent patients, because if we don't handle this immediately, they're going to lose functionality. They're going to lose parts of their brain to ischemia. So it's just very important. This is a medical emergency. So these pictures have a little bit of differentiation between the left and the right stroke. So much of our brain injury kind of just depends on where it is. Where was the bleed? Where was the injury? Where was the obstruction? Left brain is more analytical thinking and language. The right brain is more visual, more special awareness, and that perception that gives us the awareness of where our body is and space and time. Take a look at these pictures and kind of see like if the damage is occurring on one side versus the other, and compare what we typically will see as manifestations of those damages. Our nursing diagnosis for the person that has had a stroke: impaired swallowing, risk for impaired gas exchange, sensory perception, impaired physical mobility, impaired communication, impaired coping. Again, it just kind of depends on where the damage is occurring, where we're going to see the issues. A person that has had a stroke is going to have serial neurological assessments every 1 to 2 hours. It's going to be, of course, dependent on your hospital policy. We're going to look for changes in level of consciousness. These are early indicators of ICP. We're going to look at neurological deterioration. We're also going to have to look and assess when they have received TPA. They're now at a very high risk for a bleed. So maybe they did have an ischemic stroke, but because they had this huge clot buster given to them, now they start having problems because they have a brain bleed. So now we have a switch to a hemorrhagic issue. These are going to be very, very important to assess. So they have scales for this. They're going to include that level of consciousness, motor strength, what are their eyes doing, and they can be performed every 15 minutes for 6 hours. Every 30 minutes for 2 hours, and then every hour for 16 hours, just to make sure that hopefully this person is safe. We're going to, check our vital signs. We're going to look at our neurovascular assessment, checking our pulses. We want to make sure that there's not some additional clotting going on. We're going to assess the puncture site used in the arteriogram to detect any signs of bleeding. We're going to look at doing an ECG and cardiac enzymes, because sometimes, a lot of times, if we are having a stroke, it can be because of AFib. A lot of times we haven't figured out that the person has AFib until they have a stroke. So they're going to take a look at that ECG. We did a lot of echoes in the hospital just to see kind of what they were doing, and getting a 12-lead ECG to see what's going on in there. Serum electrolytes, particularly sodium, that's a common problem after we've had a stroke, is the hyponatremia. So, specifically SIADH and the cerebral salt wasting syndrome. This can cause cerebral edema and neurological deterioration. We're going to look at their input and output, that cumulative fluid balance. This is going to help us evaluate that potential sodium and water imbalance, as well as approximating volume status, especially in patients receiving the Triple H therapy. So our nursing interventions are going to be administer the TPA as ordered. It's going to dissolve that clot and restore blood flow to the ischemic tissue. It is administered intravenously, and it is used for treating that ischemic stroke and is currently the only treatment approved by the FDA for ischemic stroke. In order to receive the TPA, patients present within 3 hours of stroke symptoms, meaning if you ask the wife and say, well, they think their husband had a stroke, the last time she saw him normal was at bedtime, the night before, they're probably not going to give him TPA because likely he had the stroke in the middle of the night and it could be hours, and it's not safe to give them the TPA after that. Some people, some organizations and hospitals will do it up to 4.5 hours. It's really up to your hospital policy, but it's typically around 3. We're also going to want to perform a bedside swallow study. After stroke, many patients experiencing swallow dysfunctions and puts them at risk for aspiration and pneumonia. So swallowing is pretty complex, and they're going to test cranial nerves 9, 10, 11, and 12. They contribute to swallowing, and they innervate the palate and the pharynx, which assist in airway protection. So if those those cranial nerves have been damaged, we will see aspiration of food and fluid into the lungs. We want to elevate the head to greater to or equal than 30 degrees, especially if that patient's at risk for exhibiting the clinical manifestations of increased ICP. Efforts will be made to keep that patient's neck at midline. There could be a possibility of a nasogastric tube. If swallowing is very highly affected, we're going to implement aspiration precautions, which means thickened liquid, increasing the head of the bed. We're going to want to make sure that they're tucking their chin and swallowing. We're going to have those fiber additives added into the liquids. We're also going to look at bleeding precautions, because people that have received the thrombolytics or anticoagulants, they're going to have a lot of issues for bleeding. So, soft toothbrush, alternating that blood pressure cuff from the left arm to the right arm, avoiding rectal temperature measurements, observing strict fall precautions, because they can definitely have some significant bleeding. Patients who have received thrombolytics for acute stroke are typically considered to be at high risk for bleeding for up to 24 hours after the thrombolytic administration. Patients receiving anticoagulants are at risk for minor and major bleeding events throughout the course of their treatment. So we want repositioning, elevate paralyzed or weak limbs to minimize dependent edema, advocate for the evaluation of patients with OTs and PTs. Patients with hemoparesis or hemiplegia are at greater risk for the development of pressure injuries because of their decreased mobility. Frequent repositioning allows offloading of pressure from bony prominences. Definitely, when you talk to those OTs and PTs, get some passive or active range of motion regimens and functional splinting. It will prevent musculoskeletal and functional complications that can hinder a patient's rehabilitation. Education for stroke patients is very important. We want them to understand what type of stroke they have and how they can get the best kind of care. When you've had a TIA, when you've had a stroke, you are more likely to have another stroke. We need to have them understand those signs and symptoms. And a lot of times I will see patients that their first view of a stroke is not necessarily that standard face, the face, arms, face, arms, speech, and time. It'll be something where the patient's really just off, and the wife is like, something's wrong, something is off on this patient, and a lot of times you'll find that they've had brain bleeds. If they feel really like something's going wrong, they should probably take them into the emergency room. Patients with ischemic stroke should be educated to control their cholesterol and blood pressure. This will include then medication management education and how and why these are so important. Patients and their families should receive specific care regarding their stroke and making sure that they understand how to take care of their family member because they've had a stroke, and when they need to call 911. You know, let's find out what are those warning signs, what are the symptoms of a stroke. It's also very important we educate them to quit smoking. Smoking, not managing your diabetes, all of these can lead to, again, additional damage to the brain through these kind of things. So many risk factors for stroke may be controlled: smoking, hypertension, hypercholesterolemia. Knowledge of those roles and those factors and how they kind of play together, it really empowers patients to take control of their health so they can maybe prevent another stroke. Quit smoking, and then how important are those medications that they have to, you know, reduce their blood pressure and they reduce their cholesterol. You know, in order to increase adherence to medication regimens, factors such as medication costs and financial resources, as well as their side effects, should all be considered.